Good morning. Um, my name is Red Schiller. I'm President for Academic Affairs at the Institute for Family Health and interim chair of family medicine at Mount Sinai. And we are in for a treat this morning in our grand rounds. We're having Dr. Mitchell Katz, who's the President and Chief Executive Officer of the New York City Health and Hospitals Corporation. He's going to talk about the issues that our communities are facing around the healthcare crisis in New York City and in this country. The Health and Hospitals Corporation is the largest municipal healthcare system in the United States. The workforce of more than 40,000 healthcare professionals across a network of 11 hospitals, 5 skilled nursing facilities, dozens of community health centers, a home care agency, and an insurance plan, Metro Plus, which many of us work with. Since Dr. Katz's appointment in 2018, the corporation has significantly expanded access to a wide range of healthcare services, including the creation of NYC Care, a universal health access program for uninsured, serving more than 100,000 members. Under his tenure, Dr. Katz has overseen the adoption of modern electronic health record system. They're also on Epic, and that's a great way that we can collaborate. He's increased the number of nurse positions in the system, developed a modern ambulance transport system, and expanded outreach and housing programs to improve the health of people who are undomiciled New Yorkers. He also led a financial turnaround of the corporation by eliminating a deficit through enrolling more New Yorkers in health insurance and improving their billing and collection efforts. Through the COVID pandemic, Dr. Katz provided strategic guidance to the city, directing the public health system's response to the surge of patients, tripling the ICU capacity at its hospitals, led the city's test and trace operations, including administering 18 million COVID tests and more than 1.3 million COVID vaccines. Under his leadership, the corporation also provided more than 18,000 vaccines to quell the Mpox outbreak and has provided food, shelter, and supportive services to more than 20,000 asylum seekers. Dr. Katz completed his medical degree at Harvard Medical School and his internal medicine training at the University of California at San Francisco. And currently, we're collaborating, the Institute and the corporation, with residency rotations, enhancing our referral relationships, and expanding residency opportunities. One housekeeping issue, if people could fill out our grand rounds evaluation at the end, that really helps with maintaining our CME accreditation. And I'll turn it over to Dr. Katz. Thanks again for being with us.
Oh, thank you for that nice introduction, Red. I really appreciate it. I'll mention that of all the things that I do, the hardest, the most rewarding, and the thing that I feel strongest about is being a primary care doctor. And I say that to commend all of you who are, in training, or those of you who are family practitioners, that is the soul of what we do. Everything else I do is meant to try to make it easier for all of us to take care of our patients, for our patients to have access. But the whole goal is to be able to make sure that everyone has a relationship that is healing with a primary care doctor, whether that's a family practitioner or an internist, or for a woman, a OBGYN. The important part is that it's continuity in care. It's us getting to know them. It's them trusting us. It's our understanding who they are and what they need. So that will always be the most important thing to me. So Red gave you a sort of listing of what we do. I want to talk a little bit about how I see health and hospitals as different than all the other great hospital systems in New York City. And we are lucky to have many great systems, including Mount Sinai, that are in the city. There are two areas where you can see the differences the most. One area is the difference between medical care and behavioral health care. So we do 20% of the medical beds in New York City, but we do 60% of the behavioral health in New York City. And I think that that's because the reimbursement rates for mental health are low. Hospitals are not as interested in doing that work. We do it out of mission and recognizing that that's what, in fact, New York needs of us. So one of the characteristics of a municipal-based system is that we're really here to do the city's work. And so in some way, that was also true in COVID. People could get a vaccine in their system. So if you were a Mount Sinai patient, you got an email from Mount Sinai saying you could get a vaccine at Mount Sinai or NYU. But we were the place that you could get a vaccine if you weren't affiliated with anyone. So, that aspect of who we are, I think, is very key. The other place where you see it, and it's important to the discussion of how we work together well with especially federally qualified health centers and primary care family practitioners providing elsewhere, is that we provide the same standard of care to everyone. Now, if you say that, you might say, well, wait a minute, when Mount Sinai, NYU, all of the great hospitals will all take patients from the emergency department who are uninsured or who have Medicaid. The big difference is that's all under the EMTALA laws, Emergency Medical and Labor Act, that requires that all hospitals take patients from the emergency department without regard to whether or not they can pay. Doesn't prevent hospitals from bankrupting patients, doesn't prevent hospitals from sending collectors to get their money, but it does mean that a hospital can't say, you can't come here, you have no insurance. So all of the hospitals in New York City can rightfully talk about the patients that they care for who have Medicaid and who have no insurance at all. The difference is from the inpatient to the outpatient level is in the inpatient area, hospitals get paid for that. Under emergency Medicaid, all hospitals are paid for hospital admissions, regardless of whether or not the person is insured. Let's turn that now to look at, what the situation is in an outpatient area. There's no reimbursement. The person is uninsured. There's zero reimbursement. So this is where I feel Health and Hospitals really shines, because when I'm in practice, where I see my patients, which is on the Lower East Side at Gouverneur, if I'm taking care of a patient, say, who has diabetes, and I think that the right next drug is Ozempic, they're already on metformin, and I'm going to add Ozempic, I just send the Ozempic prescription down to our pharmacy, and they walk away with 3 months of Ozempic at $12,000. That you cannot get. When one of my patients needs an MRI and they are uninsured, ironically, I have a much easier process than if they're insured. If they're insured, I need to get a prior authorization for their MRI. If they're uninsured, I just order the MRI and they will get the MRI. So we are committed to the practice of single standard of medical care. And we extend that as well when it comes to things like pharmacy and MRI or other advanced technology. So a recent patient of mine is in an accident, and she goes to one of New York City's finest hospitals. She gets good emergency care. She calls me a week later, distressed and perplexed. What is the issue? At the fine New York City hospital, they gave her a list of 3 orthopedists, and they said it's very important that you follow up with these orthopedists in 7 to 10 days. She's conscientious, wants to make sure that she is getting appropriate care. She tells me, I called all three offices, but none of them are willing to see me. I don't understand. She was not uninsured. She just had Medicaid. None of the doctors in the outpatient area from that hospital take Medicaid. That's the difference between health and hospitals and many of the great New York City hospitals is that we will always take people for follow-up care, whether they're uninsured or they have Medicaid. The same is true for when it comes to pharmacy, as I was saying. So I know that at federally qualified health centers, like at health and hospitals, patients are going to be seen without concern for whether or not they are insured, and they're going to see excellent doctors and nurse practitioners and other caring people. Where the hole comes in usually is medications, right? What federally qualified health center is going to be able to afford to send people out with Ozempic? Advanced imaging. Patient gets mammogram, that's good. But what if the mammogram is abnormal? What happens next? How does that woman get the ultrasound, the MRI, the biopsy? Because the scope of federally qualified health centers is usually limited to primary care. Each center gets to define primary care a little bit differently. You might be able to have a dermatologist, for example, but in general, you're not going to be able to do advanced imaging. You're not going to be able to do interventional procedures, open biopsies, colonoscopies, the things that patients fully need. So federally qualified health centers, from my point of view, are a critical part of the access that we need to provide to New Yorkers. But the hole that's still left is when people need more than even the very best doctor, nurse practitioner, or social worker can provide. The other thing that health and hospital, I think, shines on, and I think this is also true of community-based organizations and many federally qualified health centers, is recognizing that the difference between health-seeking behavior of middle-class people and health-seeking behavior of people who live in poverty. So in taking care of people who are middle class, you can generally assume that if you give them an appointment for next week at 2:15, they'll come next week at 2:15. For my patients, a critical question when setting the time is, when do you get off from work? Because I know that they don't have any sick leave. If I give them an appointment at the beginning of my schedule, they're going to have to miss a whole day of work. Transportation. One of my patients needed a colonoscopy. When I saw him, all I could see was colonoscopy canceled by patient. I say to him, did you change your mind about getting the colonoscopy? He says, no. I had arranged with my friend to take me to the colonoscopy, but at the last minute, she had to work that day. I was thinking to myself, well, if I needed a colonoscopy, sure, I would arrange with a friend, but if my friend couldn't do it, I would immediately go into problem-solving realm. What other friend could I get? Who could I get an Uber there, get somebody to meet me there? But he couldn't get an Uber. He doesn't have the money for that and doesn't have another friend who could do it. People's lives are different. Often, as all of you know from your practices, middle-class people often can prioritize their health and their medical treatment because their other needs are filled. They have a steady place to live. They know how they're going to get their next meal. Their children are safe. They're safe from violence. Many of the people that we take care of are homeless, are not sure where they're going to get the next meal from. Um, they are sometimes addicted to drugs. They need mental health medications in order to function. And so then what matters for us is to create a healthcare system that works for them. That's on us. That's not on them. They are, often doing things that we would find impossible, like taking 3 buses to Bellevue with 4 small children, right? They are doing heroic actions in order to be able to take care of their families and their needs. But then we need a healthcare system that recognizes that perhaps housing is the most important thing that we can do for this person. Or maybe in the absence of transportation, we're not going to be able to see them. Or even more recently, and I'll bet many of you have had this experience, patients of mine who've called and asked for a in-person visit to be switched to a phone visit. And the reason is they're afraid to go out because of ICE. They're afraid that if they come to see me, they'll be leaving their homes, and by leaving their homes, they'll be at greater risk. They're not worried about ICE at our facilities. They're worried about ICE as they leave their apartments. Um, when we can do a phone visit and meet the needs of the patients, that's great. Sadly, that sometimes is not the case. One of my colleagues has a patient who's pregnant who needs an ultrasound and is afraid to do anything other than a phone visit, right? Unfortunately, my excellent colleague, who's a wonderful obstetrician gynecologist, can do everything, but she cannot do an ultrasound over the telephone. So our patients suffer because the other circumstances of their life make it so difficult. So that is, I feel incredibly lucky to be in New York City, especially at times like this, and to work for an organization like Health and Hospitals that is able to provide a single standard of care to everybody. And I enjoy very much our collaborations, especially with the providers like federally qualified health centers and other community-based agencies that I feel really understand our patients and create systems that are designed to help them. So in the last part of my talk, I want to think out with you about sort of, what the current situation is politically, and, how we all, as value-driven people who care deeply about our patients, how we respond. Very, very tough time. And I began with ICE. And so, I want to talk a little bit more about the immigration situation. Uh, every administration in recent years has done deportation. Deportation is not a new thing. It's also true that no country has open borders. All countries have rules about immigration. What has been upsetting to me is that the way that people have been operationalizing the ICE in ways that I think are really meant to frighten people and to frighten people who are doing good work, who are taking care of their families or in mixed families, people who are the kinds of people who built New York. And the idea of creating so much fear, unhappiness, the idea of, no longer respecting healthcare sites and churches and schools as places that ICE does not go, which is one of the big changes. Again, deportation, not a new thing. ICE going into schools, churches, healthcare areas, that's a new thing. And it's not a nice thing. And it really, I find incredibly upsetting. One of my patients talked to me about that when he grew up, his parents divorced, and that was incredibly distressing to him. And so he made a commitment to himself that he would always be there for his children. Only problem is children US born, wife US, he has no status here. He's like, well, so now what do I do? Do I return to my country and abandon my family after I promised that I would stay always for them? What do I do? And I'm sure many of you are aware of families that have signed over custody of their children to friends and relatives to return to their countries of origin, hoping that maybe when their children turn 18, they'll be able to sponsor them and families be reunited. It's a devastating thing. And especially with regard to healthcare, right? We are healthcare providers. We are doctors and nurses and PAs and social workers. We're here to take care of people. We're not here to, you know, interrogate them on their immigration status. And sadly, we've also all learned how complicated immigration status is. Immigration status is not you're a US citizen or not a US citizen, right? There are all these different levels. And then beyond the issues of immigration, we're now going forward, the federal government on limiting who will be able to stay on Medicaid through work requirements and frequent re-enrollments. And these work requirements and re-enrollments are really just ways of helping to push people off Medicaid, off benefits that they are entitled to. When Arkansas did work requirements, it had no effect on how many people were working. It only had an effect on how many people fell off the rolls, in part because of what we talked about. If you're, working for wages to keep your family going, you have no sick leave. How much do you think you're going to prioritize registering yourself for, the next 6 months of Medicaid? What about filling out the forms for, proving that you're working? So if you actually look at the work requirements, in theory, they're not so terrible. What the work requirements say is that you have to be working or engaged in a volunteer job or taking care of small children or disabled from working or in school. Well, I believe in work. And I don't think that's necessarily a bad thing, especially if you allow people to either be in school or volunteer if they don't have a paid job. The problem is that we know our patients and we know where they're going to lose benefits because the form is not going to be filled out, or the form is going to be filled out and sent to an office and the form is going to be lost, or someone's going to say that the form doesn't signed or it doesn't have the office stamp, there's no correct fax number, and people are just going to fall off. And it's not designed for people to make sure that they work. It's designed to help push people off the rolls. And then it will cause for our systems, especially for health and hospitals and for federally qualified health centers who focus on the care of Medicaid patients. If there are fewer Medicaid patients, there's less money to care for everybody, and those people will still need care. There's nothing about falling off Medicaid that reduces how much care you require. Um, so people who are sick are still going to be sick, are still going to need care, and are going to come to us. Whatever savings will come because we're not providing the preventive care, like treating people's blood pressure, will just pay higher amounts later on when they have their stroke or heart attack because we weren't able to prevent it through very inexpensive medications for hypertension. So, we are, I don't want it to all be, gloom without solutions. I believe in gloom with solutions. We're actively working with the state and the Department of Social Services in the city to try to figure out, okay, well, let's look at this a different way. How do we make sure that nobody falls off? If I'm right that almost everybody could be working, doing volunteer, taking care of young children, uh, disabled from working or in school, then it's a paperwork issue. Okay, so we're bureaucrats. We should be good at figuring out paperwork. Uh, we're not sure whether we're going to do it, but just to give you an idea of the kinds of ways I think we should go about this, I've been talking about, well, volunteer, the issue will be how will we prove that people volunteered? And I'm thinking maybe I want them to volunteer at my skilled nursing facilities. The nice thing about my skilled nursing facilities, of which we have 5, is that they're open 24 hours a day, 7 days a week, Saturdays, Sundays, and there are always people who would appreciate someone to talk to. The only skill that you would need to be useful at a skilled nursing facility is the willingness to talk to somebody who's lonely and doesn't have anybody to talk to. People hunger for contact. Okay, well, if that's true, could I have an organized program and could I be in charge of the paperwork, right? Could I create a system where I know whenever people are in my facility, I total the hours, I stamp the form, I send in the form. I can't tell you yet whether or not that is fully viable because we don't yet have the state rules about what it's going to be for the volunteer requirement in terms of hours, whether there are going to be any limits on where people can be, what the exact paperwork requirement will be. I will tell you, if you haven't already heard, that with regard to food stamps, I'm sorry, it's SNAP. I'm dating myself. With regard to SNAP benefits, the Department of Social Services already has a form on their website for providers to sign to indicate that someone is disabled and cannot work so that they can continue to get their SNAP benefits. So you might, I think it's going to be sometime I forget whether it's February, March, that those requirements for SNAP, they actually go into effect earlier than for Medicaid. And so we all need to be, good about making sure that our patients who will not be able to document work because they are disabled from work, we've filled out the forms and sent them with our patients, recognizing that after we dutifully print out the form, sign the form, give it to our patients, some of those forms will get lost. And we need not blame our patients because I can't tell you how many forms in my personal life I've lost. I'm actually very good at paperwork in the office. When it comes to home, it's all a mess and I can never find anything. So I just recognize that the challenge that's before us. So hard times call for, better leaders. I always feel like anybody can lead during easy times. Leadership doesn't really matter that much if things are good. It's when things are hard that you really have to look around and ask yourself, who are your friends? Who are your allies? Who are the people who can help you fulfill your mission about the people you care about? And I'm so honored to have such great colleagues like all of you today who are taking care of people with the same concerns as I do, and making a difference. So with that, I'm going to stop, Red, and this is an issue where we're happily not talking about a rare rheumatological manifestation that I can't remember much about without looking up on UpToDate. We're talking about an issue that all of us have experience on, all of us have opinions about. Many of the people in your audience, Red, may have ideas that I haven't thought of, and I'd like to use the time we have left to hear from people.
Sure. Thank you, Mitch. And just, I think your comment about gloom and solutions, um, I can't tell you how refreshing and energizing it is to have a hospital leader share our mission and share really the scope of what we need to do to fix a broken healthcare system. And I think, we may be well poised to make a difference. One thing I'm just wondering about is, um, what's clear from what you said in our work, there's a role that advocacy plays in primary care more than ever. And I'm just wondering what your thoughts are about having the community health centers, FQHCs, and the corporation to work together, to come up with solutions specifically around the Medicare, what's going to happen with Medicaid, what's happening with SNAP, what's happening with immigration. Like there's certainly more of a role of advocacy, and I would wonder about your thoughts about that. And one comment is, I think that advocacy in these conversations are a part of dealing with the burnout that many of us are feeling in primary care. The scope of what we have to do is so enormous. And young physicians, I think, need the inspiration of leaders like yourself to be able to say, yeah, I can rise to the occasion, and I'm working with organizations and folks who will make a difference. Um, Sort of just your thoughts on some of those
Sure.
comments.
Uh, well, Red, I think you've hit many of the big points. I mean, I will always advocate, but I also think that we may be in an era where coming up with solutions is more important because it's not clear to me who's listening, right? I mean, I to editorialize about, the government reopening. My view, and again, people can have different views, is the government reopened because people were not able, mostly not outpatients, couldn't take air flights that they wanted to take. That's why the government reopened. The fact that SNAP benefits weren't being paid, that was not why the government reopened. People could accept that, oh, poor people won't have enough food to eat. But wait a minute, I have that flight on Sunday, and I've heard there are terrible delays. Um, so just a way of saying, true political advocacy requires that you believe that you can, through the lawmaking process, make a difference. And one of the things that's been discouraging, right, is that we haven't. I mean, we were not able to prevent HR1. I mean, HR1, we should have been, and it wasn't for lack of trying. I think we all continue that, but I am more at this moment focused on, maybe what might be called the resistance as opposed to the, turning it around, right? So, okay, so I lost, right? I called people, I wrote editorials, I talked to politicians about how harmful work requirements were. I talked about how there was evidence, right? There's actually evidence on the failure of work requirements to get people to work and how all it does is push people off. But we lost. And it wasn't even that close. It wasn't that close. So, we got to continue advocacy, but I feel then, all right, so if I lost the battle on work requirements, can I win the battle on getting everybody covered? How clever can we be? How well can, right, some of the patients that I see also go to FQHCs, some of the patients that you see wind up at health and hospitals. How do we find a movement of making sure that everybody has that form filled out. And that form, do we send the form ourselves? What, how do we, how do we do that? So, that is the part. The other thing, Reg, you've given me a chance, a different opening. I want to talk about um, burnout. One of the reasons that, and again, these are just my views. I don't want it to be a teaching point necessarily, especially for the residents. I'll just tell you how I feel. I feel that to some extent, people are focusing too much in primary care on the check boxes of, did the person have a mammogram within the last year? What is the alk phos level? Let me, adjudicate the medications, all of which has to be done in some way at some time. But the real part of primary care is being a healer. And especially for low-income people, they often don't have a lot of positive, loving relationships and people who are trying to help them solve their issues. And I think that trying to, make sure that everybody has gotten every possible vaccine and every possible cancer screening test is often a lot less satisfying than hugging an elderly patient or helping somebody to deal with a difficult child or a housing situation that's disastrous. None of us, became physicians or nurses or PAs in order to do paperwork. We did it because we wanted to make a difference. And I think to some extent, one has to constantly fight the urge to, only focus on the check boxes and forget, that a lot of our good, right? I mean, I focus a lot on continuity in health and hospitals for our primary care providers because I say, I don't want to be an urgent care doctor. I never wanted to be an urgent care doctor. I've done urgent care. I don't like doing urgent care. I like building relationships with my patients. That's what keeps me from being burned out. If I did urgent care, I would burn out because I don't really see how I don't see it's very useful. I'm not saying anything about its utility, but at least for me, it's the relationships that are healing. And I think that's what drives a lot of us to do the work we do, to become family practitioners, to want to be primary providers, and that we have to constantly make sure that our work product is not hijacked by people who have other ideas of what the most important thing for us to be doing is. So I apologize if that's a little too,
No,
sermon.
I think you responded in, but just one comment. I think what you're talking about is restoring the calling of medicine to what, why we even went into this in the first place. And you're right, it's been hijacked. So, Eric, did you want to ask your question?
Yeah, thank you, Dr. Katz. We federal qualified health centers and health and hospitals and other systems such as St. Barnabas hospitals have a public image problem in that, and this was often reflected to me during conversations with congressional representatives, that they think that we do not provide best quality care, and that continues to be something that's in the public domain. With what's coming with Medicaid changes, and we know that we will be at the forefront of continuing to provide access and service to those patients. We still have to look at our financial challenges. Is there an opportunity for us to partner public health systems and federal qualified health centers to examine and to and advance conversations with legislatures that can help them understand our value where they can invest in our financial sustainability?
Absolutely. And I think, it's something, Eric, you've done in your career, and we keep doing. And I think we also, together have to look at how do we, maximize those things, right? So it could be that we could figure out in working together, okay, Eric, you do these things, I do these things, because if we do them in this way, we earn more, right? I mean, I saw somebody put in, how do you get the money without the clicks? I mean, I think part of it is figuring, you have to know the details, right? You have to another way to think about it is Epic forces us to do all of the clicks, but only some clicks matter, right? Epic forces us to do the clicks because Epic doesn't know which clicks matter. And so it makes us click everything. But we who are, experts on the care of low-income people, we actually know which clicks matter. And, we need to fix it. I'll tell you, Eric, just because you're raising an issue that I've been working on a little bit, and I'd be interested in people's views of it, because you raised the sort of how people perceive public systems. So when my mom broke her hip, I took her to Bellevue, where she got excellent care. Not because of me. She got excellent care because an NYU surgeon who works on both sides of the street did a wonderful job on her hip. And she was able to stand the next day and walk 2 days later. Took her home. We get the Press Ganey surveys that you all know well. I'm doing the survey with her. I say, how would you rate the quality of the physician care you receive? She says, excellent. How would you rate the quality of the nursing care you receive? She said, excellent. How would you rate the overall hospital? She said, excellent. Would you recommend this hospital to friends and relatives? She says, no. I say, what? Why did you just say no? She said to me, it's a public hospital. Really interesting, right? My very middle-class mother who grew up in Brooklyn, she grew up poor, but there's a certain perception that, once you made it, right? She was somebody who was hungry as a child, who, when you talk about SNAP, remembers what it was like to be hungry, what it was like to not have enough food on the table. But, now in her life, she was middle class. Middle class people don't go to public hospitals. They don't go to federally qualified health centers. It's seen as something for poor people. Even though, what I keep saying is, the great thing about health and hospitals, we don't do unnecessary procedures. You go to most New York City hospitals, you'll get all the care you need and then some, right? That'll never happen at health and hospitals because we're too busy taking care of the people who actually need care. And we're not on any economic incentives to do the angioplasty of your closed vessel, which happens every day in New York City. Every day in New York City, someone is doing angioplasty on a closed coronary artery vessel. Every day in New York City, somebody is doing epidural injections for spinal stenosis, even though it's been studied and it doesn't work, right? You know all of this. So, I think I've been doing a major push to try to get people in my own employment to choose Metro Plus Health. And I think the biggest problem I have is class. It's a class issue, right? The idea is that FQHCs and the public system are for poor people. And then a little bit as, Red was referring to, then what happens is all of the people who have good insurance that pays well, they go to the places, right, where the reimbursement rate is high, right? I'm going to say, real data. I'm not disclosing any secrets. NYU gets paid 3 times the amount for normal delivery as Bellevue, even though NYU doctors are doing the same deliveries. So in New York City, NYU, Presby are at the very top of the payment pyramid. Mount Sinai is in the middle. We're toward the bottom, but we're not the lowest. So you say, well, why is that? Well, that's because when negotiating with the insurance, NYU says, well, you have to pay us more. Insurance says, no, we can't pay you. That's too much. Why should we pay you 3 times as much as we pay Bellevue? NYU says, well, then we won't be in your network. Insurance company says, what? If you're not in our network going into open enrollment, then people won't choose us. Well, then I guess you'll pay 3 times this amount. And then if you follow that through, Eric, as you've had to your whole career, then NYU or Presby, they can buy stuff and do stuff that you and I can't do, right? Because they're getting Cadillac insurance at much higher rates. So then the cycle continues, right? Because then people say, well, wait a minute, the waiting room is so much nicer over there. They have amenities, they have more nurses. So the more it just cycles more and more, the people who can choose, and then you have the additional thing, which that people who are middle class and above, they will travel for care. So they'll go to the Mayo Clinic if they have to go to the Mayo Clinic. You and I know that is not the health-seeking behavior of low-income people. I can't get people from Harlem to go to Metropolitan Hospital. They're like, I'm a Harlem person. Like, okay, but I have this service available, in a more intense way. I want it here at Harlem. Okay, well, I can't do everything at every hospital. Well, I'm not leaving Harlem. Harlem is my hospital, which in some ways wonderful. But you see the challenge.
Yeah, thank you. And unfortunately, that mindset also is in those who have the impact to change the system.
Yes.
And reward the work that we're doing, which is preventing the cost of care in the public health system to rise. But unfortunately, that's not bearing out as much as we would like. Unfortunately.
No.
I know we want to be mindful of time to end at 5 of. There are questions about advocating for reform of the reimbursement system, including single payer, or Neil has raised the issue of fighting what's going on around the reduction in Medicaid. Is there any opportunity to collaborate around some of these advocacy efforts around reimbursement reform? Specifically, I think not only the issue that you raised with health systems, but also the woeful reimbursement of primary care.
Sure. Well, in some ways, Eric covered it. I'd just say, and again, these are very personal things. I don't want to spend my time banging my head against the wall. I am a Medicare for all advocate. Why? Because at the end of the day, I felt like the U.S. could get there. It probably wouldn't have been my number one choice, but I'm like, okay, we already have a Medicare system. Most people are happy with their Medicare. It's taking care of the most expensive people already because people's healthcare expenses tend to increase as they get older or have disabled for more than 16 months. It runs on a 4% admin. Let's just all be on Medicare for all. And then we will have solved the problem. And that would have been, great. And also, it's not communism, right? Private market system, right? All doctors participate. Nobody was going to be forced to be a government doctor. But we didn't succeed in that. And in the end, the insurance companies and the device companies and the pharmaceutical companies, all the people who are making money off of our patients, right? That wasn't in their interest. It would have been in our interest. So, I want to, and I do every opportunity I get, but you also have to ask yourself, what can we do in this political moment? Because in this political moment, it's certainly not Medicare for all on a federal level. I love Gustavo's bill. I have testified in favor of Gustavo's bill. And if New York were prepared to do it, I'd be so happy. So, again, we try, but it hasn't gotten as far as the governor's signature. And it's just not easy for really this needed to be federal legislation. But how do we work better? How do we show, our value? I mean, the biggest thing that is wrong with the physician NP reimbursements in this country is you get high reimbursement for doing procedures, whether they're needed or not. And you do not get good reimbursement for cognitive skills, even though think, how many, heart attacks. Eric may never have done a angioplasty, but how many heart attacks has he prevented by giving good blood pressure treatment, which is very inexpensive, right? I mean, so this is what we do, but this is not what society values. It isn't easy, and I think especially of the residents, right? It isn't easy to keep doing something that is not valued in the same way by society, unless you really, and it's, I think why my clinic day is so important to me, unless you open up your heart and you see how much it means to your patients, right? And at the end of the day, it is about those relationships. It's about those hugs. It's about knowing people. It's about the fact that you know who's sick and who isn't sick because you know them. I don't need the MRIs. I know my patients. I know who never complains, and I know who, if they, complain, much more likely has to do with their relationship with their son. I usually know even, down to the family member who is causing the problem. That's what we all do, right? That is the special sauce. And so to as much as possible, not internalize the idea that just because society would pay you more, that it is more worthwhile to keep opening up blocked arteries. And I'll make a last pitch to the residents, particularly about this. While I totally am in favor of changing the reimbursement rates so that primary care is valued, given that we are the only intervention that's ever been shown to both be high quality and low cost. But I'll also tell you that money doesn't buy happiness. Money does not buy happiness after you have paid your rent and taken care of your family's needs. So for physicians, for NPs, for PAs, to keep in mind when the data was looked at with happiness for the US, it was at about $80,000 a year, happiness peaks. That's, so at the end of the day, I'll always say, I'm happy about the relationships I've made through my care. And I hope that your residents, I know as mentors, all of you are already there, but I hope that people really can appreciate and feel good when they go to bed about the good they've done.
We agree. It's it's also part of our social movement. Just one maybe closing comment there's a couple of comments in the chat about engaging our patients as voters who've spoken in New York City. And just maybe in the last minute or so, like your thoughts about what we can do going forward with the new leadership in the city.
Right.
And, is there an opportunity to work together to come up with some even modest solutions?
I hope so. I mean, on a number of levels, I mean, it's very exciting, right? I mean, it's exciting to be in a city that would elect somebody with such progressive values that fit our patients. And, right down to the fact that I've often thought, gee, if you wanted to do one health intervention, perhaps high quality daycare would be the most useful intervention you could do, right? Because that's where so many of the problems start when kids begin school behind. And we know that daycare does make a difference in terms of where kids start at school. And if you start behind, you're likely to stay behind. So I love the idea of, I do see daycare as a health intervention. It's also for families economic support, right? And we know how important economic support is, but if you have a safe place to leave your kids that you can afford, you can go into the work market, right? And then you can work for your family. I mean, the one limitation that even someone who is as creative and charismatic as Mandani is that most health policy is at a state or federal level, right? I mean, just because the dollars are so huge and the policies aren't made at the city level, right? We're the ones who have to make what the feds and the state do work, but we're not in the driving seat. You know, Hochul has talked about, you know, being committed to the daycare. Not sure she says how she's going to get there, but she wants to work on it. And so, you know, yes, I see, you know, his victory as maybe energizing people to do the kinds of things that, you know, we believe in. So ever hopeful. Hey, thank you so much for inviting me. It's an honor to talk to people who care about these issues the way I do. And better together, right? We'll figure out going forward how to, you know, keep advocating and pushing for the people that we love. So thank
Thank
you.
you, Mitch.
Thank
Thanks
you,
so much.
Mitch.
Bye.
You're an inspiration. We're grateful for your time this morning.
Thank you.
Thank
Bye-bye.
you. Bye-bye. Have a good day, everybody.